Perfect. All right. Good morning, everyone. We're glad to have Dr. Renato Bobadilla Leon, who is an infectious disease fellow at UC San Diego. He's supported by the HOPE T32 program. Before moving to the United States for his internal medicine residency at St. Barnabas Hospital in the Bronx, he served as a sub-investigator with the HPTN and HVTN networks in Peru, contributing to HIV prevention trials among key populations. He later worked as an academic hospitalist in Pennsylvania prior to beginning his fellowship here. His current research examines HIV and hepatitis B interactions in the liver using rapid autopsy tissue approaches to map hepatic viral reservoirs. So we're lucky to have him here today. He's going to be talking about beyond Tenofovir and Entecavir, what's next in concurrent HIV and chronic hepatitis B. So Renato, I'll be checking your chat, and I'll probably try not to interrupt you unless there's something that's maybe related to what you're talking about. And I'll give you a cue around 8:45. All
Thank,
right, go ahead and take it away.
thank you. Thank you all for joining. My name is Renato Bobadilla. Today I will be presenting what's next in the management of concurrent HIV and chronic hepatitis B. This is especially important now that we are entering an era of tenofovir sparing regimens. So this talk will move beyond the traditional backbone of tenofovir and entecavir, and instead we will focus a lot in long-acting HIV therapies and its intersection with hepatitis B reservoir biology. So the objectives for today are four. We're going to review long-acting HIV treatment strategies and the implications for hepatitis B management. We will discuss occult hepatitis B infection and an isolated core antibody positivity in people with HIV. We'll also describe emerging hepatitis B biomarkers. We will summarize novel therapeutic approaches targeting hepatitis B, functional cure, and how they may translate or may not translate into HIV hepatitis B co-infection. So by the end of this talk, I hope we can think more critically about how these evolving HIV treatment strategies are changing the hepatitis B landscape. So let's start with some context. Why this matters? To understand why this matters, we have to start globally. So HIV affects almost 40 million people. Hepatitis B affects more than 250 million people. So co-infection is not rare. Around 4.4 million people live with both hepatitis B and HIV. And this is concentrated mostly in sub-Saharan Africa, Southeast Asia, and the Western Pacific. These both viruses have reservoir biology, meaning that they persist despite suppressive therapy and they can remain transcriptionally active for many years, both viruses. Clinically, co-infection, we know that accelerates fibrosis, cirrhosis, and hepatocellular carcinoma. And because of this, the mortality in these patients is higher. Paradoxically, though, these patients with the highest unmet need, with the worst clinical outcomes, are routinely excluded from cure clinical trials. And not even just patients with infections, even patients with history of exposure to hepatitis B, they are excluded from cure clinical trials. And in a more local context, we know that this year, some states moved to limit access to HIV treatment. And last year, in December, the CDC rolled back universal hepatitis B vaccine recommendations. So this means that in some years from now, the co-infection is going to be is going to increase its incidence. So it's a very important topic that we have to discuss. So now, let's discuss about long-acting HIV therapies. So in January 2021, the FDA approved for the first time the injectable drug called cabotegravir ripivirine, also known as Cabenuva. Later, in December of 2022, the FDA approved with a more specific indication, but also another injectable, long-acting injectable called lenacapavir that we all know. Because this medication is highly effective, in March 2024 and later, these medications have been tested with other therapies that are also highly effective too, um, like monoclonal antibodies, also with novel antiretrovirals. Recently, 2 months ago, there was a study showing like the combination with Entecavir in a single tablet, though, but in a phase 3 clinical trial. So this medication lenacapavir is highly effective. So also the combination of both Cabenuva and lenacapavir have been tested in people with adherence issues, and it shows it's very effective. And we have been doing this in the Owen Clinic, off-label, of course, and this is also an indication off-label, but it works. So long-acting injectables work, especially in these people with, and it's helpful in these people with adherence issues. So we know that injectables are really good and are changing the landscape for HIV treatment. But as any medication has its pros and cons and good things and bad things, the pros are many. No daily pills, improved convenience, reduced stigma, high efficacy, better adherence for some patients. But one of the most relevant and downsides of the long-acting HIV therapies is that they don't have hepatitis B activity. So what does our guideline mention about this specific situation, this specific scenario? In the section of considerations for antiretroviral use in patients with co-infections, it's very clear. So first, before we dive deeper, we have to understand the serologies of hepatitis B, which can be confusing, of course, but we're going to focus on two of them. Chronic infection, meaning positive surface antigen, and also isolated core antibody, which is the anti-HBC positive only. So what does the guideline mention about this? So they mention that there is 4 active drugs against hepatitis B and HIV, which is tenofovir, entrectinib, and lamivudine. And they recommend these medications as an ART backbone for HIV hepatitis B co-infection in the combination of TAF or TDF plus FTC or 3TC. So patients, and this is the most clear statement about this. So patients with chronic infection, meaning surface antigen positive, should avoid switching to NRTI sparing regimens without ongoing hepatitis B active therapy. But if it's necessary to switch, they recommend to maintain hepatitis B active therapy with tenofovir, staph or TDF, or entecavir. Now, translated this, it means that patients with chronic hepatitis B and HIV co-infection must take a daily pill, and if they want to switch to an injectable, plus an injectable. So this is the recommendation of the guidelines, which kind of defeats the purpose of the long-acting HIV therapy, right? Because patient has to take a daily pill anyway. So, but specifically about isolated core antibody or core antibody positivity, they mentioned that there is insufficient studies to confidently estimate the risk of reactivation. So, but they do mention they are likely a low risk of hepatitis B reactivation. However, once they subdivide the group or they classify the group as based on the history, if the patient has surface antigen positive, the risk changes significantly. So in patients who had a remote history of surface antigen positive, the risk is almost 20%. Without prior history of surface antigen is 1%. And in patients who have also surface antibody positive, it's the lowest risk, less than 1%, of course. But this 20.2% risk in people who have a remote positive surface antigen is not negligible. So it's a very important thing that we have to keep in our minds. So based on this, there was a recently published study in January 2026 that explored this hepatitis B outcomes after switching to Cabenuva in people with HIV. This was a study done in Barcelona. It was a prospective cohort study of more than 700 people initiating Cabenuva, and they followed these patients for almost a year. And among these all participants, 25% had prior hepatitis B exposure, meaning the positive core antibody, and 3% of them, so between 20 to 30 people, had isolated core antibody positive. So the findings were like in general, there was no hepatitis B reactivation or incident hepatitis B infection observed among all the participants without chronic hepatitis B at baseline, but including people with isolated core antibody. Again, they just followed the patient for 1 year. And out of all the more than 700 people, they had 4 participants that they didn't recognize had chronic hepatitis B, and they switched. And these patients were switched, all of them, back to tenofovir containing ART. In general, there was a transaminase elevation, LFT elevation of 17% in the cohort, which was not associated with hepatitis B serostatus. And also, they do mention that hepatitis B DNA was not routinely tested in all participants. So, as per the guidelines, and also our guidance mentioned that we should only check hepatitis B DNA when there is an increase in LFTs or clinical suspicion. So, this is what they did. So, in general, the conclusions of this study was that there was no hepatitis B reactivation in properly screened patients with prior hepatitis B exposure. And unrecognized chronic hepatitis B, of course, is the real danger. And LFT elevations are common, but not specific to hepatitis B. And what they recommend is a comprehensive hepatitis B screening before switching, of course. So we are moving now to a more local reality, which is our own clinic. So we presented a poster. Well, I didn't present the poster, but UCSD presented a poster in December 2022 in ID Week of a case series of low-level hepatitis B viremia in people who were switched to Cabenuva. And what they found is that out of the 149 patients who were switched to Cabenuva, 38 patients were positive for had isolated core antibody positive. Out of these 38 patients, 3 developed hepatitis B viremia. 2 of them agreed to switch back to tenofovir-containing regimens, and one of them, the patient didn't want to go back, so he remained on Cabenuva only, and they repeated the DNA levels, and they were detected at a low level, but the surface antigen never became positive. It's also important to mention that one of these patients, not this one, not the last one, but one of these patients had a positive surface antibody. So this may seem maybe not too clinically relevant or significant because it's just a case series, but in January 2025, there was an interesting study published from an Italian cohort that explored hepatitis B virus replication in core antibody positive patients and surface antigen negative with HIV switching to tenofovir sparing regimens. So this was also a prospective study in Rome of over 100 people with a positive core antibody that were switched from tenofovir-containing ART to tenofovir-sparing ART. So they use droplet digital PCR, which is more sensitive, and the lower limit of detection is significantly lower compared to regular labs, the standard labs. They quantified 2 things: hepatitis B DNA and hepatitis B RNA. They check these markers at 3 time points. So baseline at switch, before 12 months post switch, and also 12 to 24 months post switch. So the interesting findings are even at baseline. So at baseline, almost one third of the patients had cryptic hepatitis B DNA only detectable by the ddPCR. 22% had isolated detectable hepatitis B RNA, meaning it's a transcriptionally active DNA in the liver that is released into the blood that is going to be detected with this test. So again, these findings suggest that there is a persistent transcriptionally active cccDNA, which is the reservoir for the hepatitis B, despite surface antigen negativity. Now, after the tenofovir withdrawal, after the switch, so they classified 2 groups basically in hepatitis B DNA more than 10 and hepatitis B DNA more than 100. So in people who had 12% of detectable DNA more than 10 at T1 increased to 42.6% at T2. So almost maybe 1 year later, there was a significant increase. Then in people who had a higher level at baseline, increased from 2 to 11%. And Progression to hepatitis B DNA more than 10 by T2 in general was all the people who had cryptic hepatitis B DNA, 70% of them increased. 38% with isolated hepatitis B RNA at the baseline also had detectable levels and significant levels of hepatitis B DNA by T2. And people who had, and this is probably one of the most interesting things, so negative RNA, negative DNA were also, by the end of the 2 year follow-up, they did have a detectable hepatitis B DNA. And this is another conclusion, interesting conclusion, finding of the article, is that they found an association between persistent hepatitis B DNA and reduced CD4 T cell recovery. So in general, then these conclusions of the article are that virologic reactivation is common, but clinical hepatitis is rare. They did not report AST/ALT in this study, but they did mention this. ALT-based monitoring may miss subclinical viremia, and subclinical viremia may have immunologic consequences, like we saw in this finding of the delayed CD4 recovery. So then this scenario raises this question. So should routine hepatitis B DNA be incorporated into post-switch monitoring and not just ALT trigger as recommended by our guidelines? Does the persistent low-level viremia affect other outcomes in a clinical meaningful way? Not only clinical hepatitis with elevated ALT/AST, but other stuff too. And these outcomes are different in populations with higher hepatitis B endemicity, because we saw that these studies are in Spain and also in Italy. So the resources are different. And also in areas where hepatitis B is more endemic, they have different hepatitis B genotypes. This may affect also the outcome. And also in these areas, they have lower CD4 natters. So it will be interesting to see what is the reality in these different scenarios. So based on this, if the low-level hepatitis B viremia affect outcomes in a clinical meaningful way, I found an interesting article published in September 2021, a prospective study evaluating changes in histology, clinical, and virological outcomes in co-infected individuals in North America. So they focus a lot in fibrosis. So they found that in co-infection, more than 1/3 of patients had significant liver fibrosis despite effective ART, and almost nearly 1/4 of them had advanced fibrosis, even with undetectable hepatitis DNA and normal ALT. And normal ALT does not exclude significant fibrosis as per their conclusions, and the suppression of hepatitis B DNA does not prevent or reverse fibrosis, because they follow these patients with biopsies, liver biopsies. And another interesting finding, I think we know too, that APRI and FIB4 are not adequate for fibrosis assessment in people with co-infection. So they do mention also that the clinical events are uncommon but not negligible, because we saw that in the study by Foncilla, the study in Spain, in Barcelona, they followed the patients for one year, but this was a larger cohort up, and they followed the patient for more time, because even if the clinical events are rare, this is a scenario. This is a co-infection that is going to last for it's long life. So it's lifelong. So these clinical events are going to accumulate throughout the lifespan of the patients, so are going to become more frequent at the end. And none of these patients achieve surface antigen loss. So there are not official numbers of how many people with HIV have isolated core antibody, because they publish results of core antibody positivity with or without surface antibody positive. But based on 40 million people with HIV worldwide, and where I wanted to calculate how prevalent this may be, and in low endemicity settings like the US, it's almost around 1.5 to 3 million individuals, and in high endemicity settings, it's like sub-Saharan Africa, the prevalence it's 20 to 45%, so around 5 to 13 million individuals will have this. So in general, a global estimate will be maybe 3 to 10 million people have HIV and isolated core antibody positive, which is a significant amount of patients. Now, I wanted to dig deep into this. into this. So in 2009, there was a meeting in Taormina in Italy about occult hepatitis B. And we know that occult hepatitis B can be classified in two things: seropositive occult hepatitis B, which means the detectable hepatitis B DNA, and surface antigen negative individuals, of course, but positive for core antibody with or without a surface antibody. But also we have the seronegative occult hepatitis B, which is detectable hepatitis B DNA, and the individual should be negative for any hepatitis B serological markers. This is interesting because I was only able to find one study showing what's the frequency of seronegative, meaning all hepatitis B serological markers negative in people with HIV. And I was only able to find one study done in India that they found 323 patients with surface antigen negative and core antibody negative, and they checked hepatitis B DNA, and they found 2.2% of individuals have hepatitis B DNA in this case. And this is significant because compared to the general population, the 2.2% is significantly higher, because in the general population, seronegative occult hepatitis B is 0.16%, the prevalence. So as we know, the risk is higher. So occult hepatitis B is substantially more prevalent in people with HIV than in the general population, and the standard serological screening may fail to identify a significant proportion of occult hepatitis B in people with HIV. And we know that is now, based on this study from Italy, that occult hepatitis B is often not virologically silent, and it can carry clinical meaningful consequences. So, and now this is even more important because, again, we are entering an era of tenofovir sparing ART. So tenofovir ART, tenofovir containing ART, have provided many years of incidental suppression of occult hepatitis B. And once we switch patients to tenofovir sparing regimens, this may unmask previously suppressed hepatitis B reservoir with its clinical consequences. Now, that's why functional cure is very important, because it will remove the dependence on hepatitis B active ART in patients with this, even in patients with isolated core antibody. But this remains an unresolved challenge. So now let's talk about hepatitis B biomarkers. We all know the old traditional biomarkers: hepatitis B surface antigen, surface antibody, core antibody, E antigen, E antibody, and the virological markers, which is the hepatitis B DNA. And we know the trend and how they increase depending on the phase of the infection. These biomarkers answer the question, is this virus present? But now we have these new emerging hepatitis B biomarkers. We have quantitative surface antigen, we have the hepatitis B core-related antigen, and hepatitis B RNA. And we see that they also change according to the phase of the infection. However, we also see that within the same phase, they have a particular trend too, and they vary also within the same phase of the infection. So these markers answer this question: is the viral reservoir transcriptionally active? And to understand this, we have to understand what they measure or how clinically relevant these are. We have to go into the biology of hepatitis B. So we have the virus that attaches to the NTC receptor in the hepatocytes and undergoes encoding in the cytoplasm. Then it goes within the nucleus and the capsid is removed. This is a type of DNA of the hepatitis B called rcDNA, or relaxed circular DNA, that undergoes reparation, and it is completed and transformed into cccDNA, which means covalently closed circular DNA, which we can consider as an extra chromosome within the nucleus of the hepatocyte. And this is important because this is the most important part of the reservoir of hepatitis B. And that's why we cannot cure hepatitis B so far, because of this cccDNA. So this cccDNA is going to be transcribed into pregenomic RNA, and this is going to be reverse transcribed into a double-stranded linear DNA. And because it's linear, it's going to integrate into the DNA of the hepatocyte, as we see here. This is going to be transcribed, and even though this integrated DNA cannot produce fully competent viruses, it is going to transcribe into surface antigen subviral particles. So it can be transcriptionally active, but it's not going to produce fully competent viruses. So going back to the cccDNA, it's going to be transcribed into 4 types of RNA: subgenomic, pregenomic RNA, polymerase RNA, and pre-coded RNA. So the subgenomic RNA is going to produce surface antigen. The pre-coded RNA is going to be an open reading frame that, according to where it's read, is going to produce 3 different antigens, 3 different proteins: core antigen, E antigen, or the P22CR. The polymerase RNA is gonna be translated into polymerase, and the pregenomic RNA is gonna go within the cytoplasm, and it's gonna create a complex with the polymerase, and the core antigen is gonna form the capsid around it. So, and after this, the pregenomic RNA is gonna undergo reverse transcription and gonna form the rcDNA. This rcDNA is going to be coded by the surface antigen and is forming the envelope, and this is going to form the virus that is going to be ready to be released. Now, why this is important? Because with the RNA, we measure the encapsulated pregenomic RNA, and also we measure the correlated antigen, which are these 3 proteins from this pre-coded RNA. So this is important because even though that we know that the cccDNA is the reservoir and can produce competent viruses, not all of the cccDNA is going to be transcriptionally active, because there are some of them that are going to be silenced epigenetically. So we need to know what part of these cccDNA are going to be active, producing active viruses, right? So that's why this is significantly important. So I was checking to see if these new markers have been validated and compared to the conventional markers, and they have. And the biggest group, the biggest cohort, was done in patients with hepatitis B monoinfection, though. So in these patients, what they found is that the detectability of these markers differ markedly between in patients depending on the E antigen status. So hepatitis B RNA was quantifiable in 99% of E antigen positive participants and 58% of E antigen negative participants, and the crack was quantifiable in 20% of E antigen positive participants and 51% of E antigen negative participants. So both markers, hepatitis B RNA and crack, are correlated strongly to hepatitis B DNA, regardless of E antigen status. It's correlated also with the surface antigen, but only in this subgroup of patients who are E antigen positive. So they also measure how this the association between these markers and disease activity indicators. High RNA levels and high crack levels were associated with higher ALT, higher APRI, and higher FIB4 levels, but only in patients who were E antigen positive. So in conclusion, this article mentioned that there is limited additional value in differentiating chronic hepatitis B phases because of their strong association with hepatitis B DNA. So they mentioned that it's enough with the hepatitis B DNA to make the clinical decision to treat or not to treat. So in general, the routine clinical management of untreated chronic hepatitis B, in this scenario, novel biomarkers do not change the clinical decision making based on what we found in this article. But we also see that there is a blind spot in hepatitis B E antigen negative, because these markers, not even the old markers, measure what's happening in these patients, in this cohort of patients. And they do mention, though, that the value of novel markers lies elsewhere. Why? Because it's uniquely informative in treated patients. Because when we start hepatitis B active ART, the hepatitis B DNA is going to be undetectable, but we see that even though we have these undetectable DNA patients, um, it can remain transcriptionally active despite this negativity. So it's gonna give us that a false impression that we're controlling infection, but reality is that we are not. So, but this can be used maybe for clinical trial design, but at that time, this was only an exploratory. So they didn't replace the old biomarkers for research purposes or clinical trial goals, aims. So, but again, this is only for hepatitis B monoinfection. However, in 2023, there is two studies that studied these novel biomarkers in people with co-infection. In general, based on these two studies, because it was basically the same group of people who did these two studies, HIV, the conclusion was that HIV creates a two-disease model within hepatitis B co-infection. We have the group E antigen positive and the E antigen negative, and they behave differently. So in E antigen positive, the main finding is that in people with the co-infection that are E antigen positive, we are the current ART is under treating them. So why? Because they saw that there is 100-fold elevation in hepatitis B RNA, meaning transcriptionally active reservoir, compared to monoinfection. So this is a very important finding, meaning that the HIV acts as a synergistic mechanism to reinforce the production of hepatitis B RNA. And in E antigen negative patients with the co-infection, the ART has reached a therapeutic plateau. Why? Because they found that even with the dual active therapy and suppressive therapy for the DNA, the RNA and crack never decline over 192 weeks, which is also an important finding of this. And they think that the RNA was a better measure in this than the crack. And also, they do mention that serum markers alone are insufficient to assess liver disease severity. So there was an update in a new concept also that was published and in a recent update from the guidelines for chronic hepatitis B that I want to also mention during this presentation. It's a new concept, and I wasn't familiar until I read these guidelines. So we know there are three categories of cure in hepatitis B. We know complete cure, the concept of complete cure, that means that eradicating all hepatitis B DNA integrated and CCC DNA, but this so far it's only theoretical only. So we're not gonna be able to achieve that. Now we have the concept of functional cure, which means surface antigen loss with undetectable hepatitis B DNA of treatment for more than 6 months. This is achievable but rare. But now we have this partial cure concept, which means low level of surface antigen with undetectable hepatitis B DNA of treatment for more than 6 months. This is more achievable and has been accepted as an alternative endpoint in cure clinical trials. To understand this, we have to see where it comes from the cccDNA and how is the pattern of cccDNA and integrated DNA. So the cccDNA and the integrated DNA are only going to be measured within the liver. But we see that the total hepatitis B DNA in the blood with treatment, it's going to be below the lower limit of detection immediately after treatment, but these are going to remain active. So um, as I mentioned, it's only in the blood. So what the functional cure wants to achieve is that the surface antigen becomes negative. And how we're going to make this surface antigen become negative? Well, through decreasing the level of production from the cccDNA and also decreasing the level of production from the integrated DNA. So this is basically the concept of functional cure. So for hepatitis B, HIV co-infection, these same guidelines, which is for hepatitis B mainly, they do mention that co-infected individuals should be excluded from discontinuation protocols. And the concept of this low-level surface antigen, the concept of partial cure, has not been validated in this population. And why is that? Well, we know that co-infection may paradoxically favor cure. We know that the rate of functional cure in co-infection is significantly higher than hepatitis B monoinfection. So almost up to 20% there is almost up to 20% chance of surface antigen loss, especially in the first 2 years after ART initiation, which is significantly higher compared to the almost 1-2% of spontaneous cure in people with hepatitis B only. And this is more interesting because in areas with a higher endemicity of hepatitis B, they found that there is almost up to 34% surface antigen loss during ART. And once they subdivide patients by who developed iris and who did not, in people who develop iris, there is up to almost 75% of hepatitis B in these patients and 20% in those without iris. So there we, based on everything that I discussed just now, there is significant gaps here in hepatitis B and HIV co-infection. So we know that emerging biomarkers have not been validated to monitor functional or partial cure uh, because the low-level surface antigen less than 100 threshold may have a different biological significance. And why is that? Because there is unique virologic and immunological challenges. We know that fibrosis predictions differ, and these markers don't help. And also the hepatocellular carcinoma risk calculation differ. And also we know that the CD4 pattern is different in people with hepatitis B co-infection and HIV. So we have this scenario. We have three groups of people. We have the people with HIV and hepatitis B. We have the group of people who have HIV and isolated core antibody on ART. And we have it's less people, but we have the people with HIV and isolated core antibody on long-acting injectables. So we're pursuing now the functional cure to make that people with co-infection go to this group of core antibody positive only. And we want people who are core antibody positive go to the group of long-acting injectables because it's easier and it decreases the burdens of daily pills, which is important in a lot of people. So this is the research gap that we want to focus on. So the research gap, we know like several things. We know that hepatitis B testing, we can do it routinely. And also we know that long-acting injectables are our reality already. So what happens when hepatitis B is not overly detectable? What happens when we have occult hepatitis B and we remove the tenofovir? Now, also we know that if we use the hepatitis B DNA, we know that there is patients with low-level viremia and never becoming surface antigen positive, and also people who have cryptic hepatitis B but transcriptionally active too. So does this subdetectable low-level viremia still can drive fibrosis? And now that we have these new emerging biomarkers are more used, we want to know if ultrasensitive hepatitis B biomarkers plus fibrosis identify patients at risk when tenofovir is withdrawn. So to explore this, we need to go within the liver. So in the liver, we have to go deeper and see the cells. So there are multiple cells in the liver. We have the endothelial cells, Kupffer cells, hepatocytes, but we want to focus on the hepatic stellate cells. So the hepatic stellate cells are important because they are non-classical APCs. They activate or suppress T cells or natural killer cells via PDL1. This is the important part. So they drive fibrosis when chronically activated. This is the cell that promotes cirrhosis at the end. It accelerates fibrosis under co-infection because there is two infections modulating this. It can be infected by HIV as well, and it's not infected by hepatitis B, but it's activated by it when all the inflammation is triggered within the hepatocyte, which is nearby. So we want to explore two things within this frame. So there is two proteins, very important proteins in both infections, BPR for HIV and hepatitis B X protein. So why are they important? Because these two proteins are they remain positive despite suppressive ART. So even in 22% of people with HIV on suppressive therapy, the BPR can be detectable. And prior studies about fibrosis in people with HIV have focused on the protein GP120, but this protein is significantly declines with ART, so it's not very helpful to explain why the persistent fibrosis keeps going on despite ART. And the hepatitis B X protein persists within the liver, even if we suppress the hepatitis B DNA in blood. So we want within our research with Dr. Janella, map the profibrogenic immunosuppressive niche in hepatitis B HIV co-infected liver tissue because we have tissue from the last gift. And also we want to explore whether tenofovir withdrawal and mask circulating biomarkers of the profibrogenic immunosuppressive axis in core antibody positive people with HIV. So this is just a research that we're going to start soon, hopefully, with the correct funding. So now we're going to discuss about therapeutic approaches targeting hepatitis B cure in hepatitis B and HIV co-infection. So there is several medications that have been studied for hepatitis B, again, only for hepatitis B, because we saw that hepatitis B and HIV co-infection individuals have been excluded from most clinical trials. However, within my research literature, I found two clinical trials that are exploring medications in co-infection, hepatitis B and HIV. One of them it's more important than the other because the first one is it was an explored phase 1 study, and the second one is a phase 3 study with right now being done. And why is this very important? I want to discuss about this medication because this medication, the bepirovirsen, has been recently had some updates. So in May of 2026, this month, the FDA this medication received a breakthrough therapy designation and priority review. And the full trial data is going to be presented next week in the European Association for the Study of the Liver Congress. So the target date for the FDA for the full review is going to be October 26, 2026. And this is supported by the data from the BWELL and BWELL2 phase 3 studies of bepirovirsen. This is not the data from the co-infection cohort. This study is still ongoing. And these other studies are already finished, the BWELL1 and BWELL2, the phase 3. And again, the full data is going to be released next week, but only for mono-infection of hepatitis B. So far, what we know about this is that it's a randomized double-blind placebo-controlled study across 29 countries. Participants were adults with chronic hepatitis B on therapy who had a baseline surface antigens level of less than 3,000. And the primary endpoint was achieving the functional cure for at least 24 weeks after stopping all treatment. And the secondary endpoint seeing the same functional cure, but in people who had lower baseline surface antigen, less than 1,000. So they haven't released the full data, but this was in the news. This was in the press release. They mentioned that this bepirovirsen plus standard of care demonstrated statistically significant and clinically meaningful functional cure rates. It was more pronounced in people with lower baseline surface antigen levels, and the safety and tolerability profile was acceptable. So that's why the FDA has given this breakthrough therapy designation. So what is bepirovirsen? And this is what I found very interesting too, and why this medication is so interesting too. So this is an antisense oligonucleotide and targets all hepatitis B RNA transcript, including messenger RNA and pregenomic RNA. So, and as we see here in the picture in the left side, and how this medication do this. So we have here in the left the bepirovirsen, which is an ASO. So this medication has a central DNA core, which is going to bind to highly conserved sequences in all the hepatitis B RNA transcripts. And this is going to form a hybrid molecule, DNA and RNA. This hybrid molecule is going to be recognized by RNase H1, and this is going to hydrolyze only the RNA strand and degrading it later. So also, there is another mechanism, and that's why this medication is so interesting, because it also has another an immunological mechanism too. So the bepirovirsen, once it's administered, it goes within the hepatocytes and immune cells, and it's transferred to endolysosomes. So within the endolysosomes, the bepirovirsen is recognized as if it was a viral RNA, because it recognizes that it's going to attach to the TLR8 receptors. And once it's attached to the TLR7 or 8 receptors, it's going to trigger a cascade of immune of uh, cytokines, and it's going to, at the end, increase the transcription of pro-inflammatory mediators and produce immune activation. So this medication has dual mechanism of action. It's uniquely among hepatitis B, that is unique among hepatitis B RNA targeting agents, because there is other medication that have been tested for cure, but it has been with another medication, an immunomodulator, like elebsiran. But these medications, when they are tested on their own, they don't achieve significant antigen loss, which this medication does. Um, and these are the results of the phase 2 studies. So in people with in people who in bepirovirsen as monotherapy achieve cure in a subset of patients at the dose of 300 milligrams weekly given in 24 weeks. So 9% on people on suppressive therapy and 10% on people not on suppressive therapy. The on-treatment surface antigen reduction was substantial. Not the cure, because the cure we see that it's 9 to 10%, which doesn't seem too big to me, but this again was taken within all the participants, not only the low surface antigen level participants, like with any kind of participant for the phase 2 studies, which for a medication just only given by itself, not with another immunomodulator, is a significant finding. Again, the reduction of surface antigen, like kind of related to the concept of partial cure, was also the reduction was substantial. So almost 60% of the participants reached surface antigen levels less than 100 at the end of the treatment, but there was a post-treatment relapse as a limitation. So this again are the results of the phase 2 studies. And we see that in this study, they found that the level of surface antigen was the best predictor for response. So we know that in general, it was 9 to 10%, but when we consider only people with less than 1,000 surface antigen, it increases. So 25% in people who are not treated and 16% on people who were treated with nucleoside analogs. So they did an ROC analysis, and they found that 3,000 was the optimal baseline cutoff for predicting response. So they also found out in these phase 2 studies that 24 weeks was better, with a loading dose as well. So regarding the post-treatment relapse, so there was another study, phase 2 study, the Be Together trial, that added interferon to the bepirovirsen, and they found that 9% of them achieved cure and 50% of them, sorry, 9% of them that were treated with 24 achieved cure in the group, the people that was treated for 24 weeks, and 15% of them achieved cure in the people who were treated only for 12 weeks, which is kind of paradoxical. So they found that the sequential interferon reduced the relapse rates among the bepirovirsen responders. The suppressed then immunomodulated strategy, right? So we suppress the surface antigen with the bepirovirsen, and then we help with the interferon sequentially. So, and this is the interesting finding that I had in this study. So they found that the earlier transition to immunomodulation captures the window of maximal antigen suppression, as we can see here in this graphic. So we see this is some transcriptomic studies done in these patients within this trial. So they found that the immune cell proliferation and activation increases by week 5, and also by week 8, we see that the surface antigen levels start to decline sharply because of the bepirovirsen. So they think that it's better to give the immunomodulation earlier so we can take advantage of this high increase in the immune cell proliferation. So that's why they think that this finding of 15% cure in people who received the 12-week regimen of epirovirsen was better. So again, the phase 3 has been completed, and the long-term durability is under study. Again, the full results are going to be released probably next week. Um, so far, it's the most advanced novel hepatitis B cure agent, enrolling only E antigen negative patients, non-cirrhotic, unstable therapy with a baseline surface antigen less than 3,000, using the 24 weeks regimen. Uh, and again, these results are going to be only for mono-infected patients, but hopefully soon we have results of this drug being tested also in HIV and hepatitis B co-infected individuals. Again, the combination strategies are the future because probably it's going to achieve higher functional cure rates. Bepirovirsen is also being studied with other drugs like interferon and other types of drugs as well. So the key takeaway points from this presentation are the following. So long-acting HIV therapy exposes hidden hepatitis B biology, and the field might not be ready for it. Occult hepatitis B infection is far more prevalent and clinically relevant in people with HIV than previously appreciated. These emerging hepatitis B biomarkers reveal ongoing cccDNA activity that the old biomarkers cannot detect. Functional cure is possible, but only in a selected subset of patients. However, co-infection kind of changes the rule. But again, these studies in mono-infection have proven that one size doesn't fit all. We have to select our patients carefully who we're gonna give the option for cure, and also who we should consider for switching to maybe tenofovir sparing regimens. Right now, bepirovirsen is the leading candidate in the hepatitis B cure pipeline, and probably combination strategies are the future, like immunomodulation after reducing the surface antigen. Um, and that's the end of my presentation.
Great. Thanks, Renato. That's great overview and kind of going through all the complexity of hepatitis B. There are a few comments in the chat that we'll go through first before I open it up.
Mhm.
So Robert Dice said, can you elaborate on the FIB4 for fibrosis assessment and why it's not adequate in co-infection? You had made that point earlier on about the FIB4.
Yes, so in this study that assessed co-infection, they found that there was advanced or severe liver fibrosis despite hepatitis B undetectable DNA, and also normal ALT. And this FIB4 uses ALT too. So if it's not going to detect liver fibrosis, then it's going to affect the whole calculation of the FIB4 and also the APRI. So that's why it's not the best. They shouldn't be used in people with co-infection.
Thanks, Renato. Again, excellent talk. Do you know, was that like an observational study, or maybe you can
I
share the
think that
link
was the
later or something?
prospective study
Oh,
done.
wow.
That's yes, by the Hepatitis B network. I'm
Yeah.
pretty sure, but yeah, I can confirm this later.
All right. Awesome. Thanks.
All right. Another question from Shannon Baucombe regarding the Sterling study. Did they have baseline fibrosis prior to Hep B treatment? Are we certain fibrosis developed on treatment?
Uh, I so they A group of them had like fibrosis like before the treatment, and what they assessed was the progression of it, even if it was treated or not treated with, sorry, if it was the DNA was suppressed in patients, and they found that because in patients without the co-infection, when we treat it, the fibrosis even regress and it's better. But in people with HIV, this doesn't happen. It doesn't improve, and in a group of patients just keeps getting worse. I'm most of them had some level of fibrosis, but I'm not sure about the numbers if how many of them had fibrosis or not.
Okay. Two more questions. One from Gabe. The current screening guidelines recommend checking the surface antibody, surface antigen, and core antibody. Should we be checking Hep B DNA as well as E antigen to detect possible cases of occult Hep B?
Probably they recommend so in our clinic we are doing kind of like routinely in hepatitis in I think when I discussed with Lucas we are checking within a month after switching to Cabenuva the hepatitis B DNA. We can pick one or the other, hepatitis B DNA or E antigen, because we here in the US we can measure hepatitis B DNA, but in other realities it's not feasible. So that's why we can rely on the E antigen. But we should check it. Like I think regularly. Because we see that there is a cryptic hepatitis B DNA in people who even don't have surface antigen positive.
Okay. Laura asked, is there any role for Hep B vaccination, particularly with more immunogenic Heplisav B and any Hep B biomarker scenarios?
So for the vaccine, it's definitely a recommendation, like we should vaccine all of the patients. However, we saw in one of our patients in the case series that even with a high level of surface antibody, he became hepatitis B DNA detectable on Cabenuva. So definitely, I think we should vaccinate all of our patients, but also be important to see how the hepatitis B and HIV uh, um, produce the immune exhaustion, and probably that's why some of these patients do not respond. And even if they have surface antibody positives, they are not going to respond so well and not going to control the infection.
Okay. And last question from Chris Matthews. What is known about the risk of hepatocellular carcinoma development in patients with subclinical Hep B?
Oh, with subclinical Hep B, I couldn't find any articles regarding specifically hepatocellular carcinoma. I found articles comparing the risk between one infection compared to co-infection, but I couldn't find like subclinical. But that'll be a good approach.
Yep. All right. I see it's 9 o'clock, so I'm going to go ahead and close the session. I wanted to thank Renato for an excellent talk. I think this is very pertinent to us as many of us transition to injectable antiretroviral therapy. So I think we will probably be having you come back in the future for future updates. So thanks again, Renato, and everyone have a good Memorial Day weekend, and we'll see you next week.
Thank you, doctor. Thank you all.
Thank you.